Hello, my name is Leslie Vanenchek. I am a speech-language pathologist at the Laboratory for Cognition and Neurostimulation at the University of Pennsylvania. I'd like to thank you for coming to visit our poster. This poster is entitled, "Do Persons with Aphasia Accurately Gauge Their Response to Therapy?" A comparison of subjective and objective treatment outcomes following combined TMS and CILT. So what is transcranial magnetic stimulation, or TMS? It is a type of non-invasive brain stimulation where an electric current is passed through a coil, creating a magnetic field. A magnetic field causes a small current to activate a small part of your brain. Constraint-Induced Language Therapy, or CILT, is an evidence-based aphasia intervention or therapy that has demonstrated positive changes, but with variable effectiveness between patients. In recent years, non-invasive brain stimulation techniques, such as transcranial magnetic stimulation, or TMS, have shown promise in enhancing recovery from chronic aphasia. So at the University of Pennsylvania, we have an ongoing clinical trial that investigates combining TMS and CILT, so non-invasive brain stimulation and speech-language therapy, if that yields a greater improvement than speech-language therapy or CILT alone. So in this poster, we looked at 4 patients. 2 received real stimulation and 2 received fake stimulation. All the patients received the language therapy. And we wanted to see if persons with aphasia accurately gauge their response to therapy. So patient 1 received real stimulation. Patient 2 received real stimulation. Patient 3 received sham stimulation, and patient 4 received sham stimulation. Our experimental design is as follows. We administered testing for all of our participants, and baseline testing day number 1, we gave the CCRSA, the Communication Confidence Rating Scale of Aphasia, which would be considered a subjective measure, the Western Aphasia Battery, the WOB, which is an objective measure, and a 72-item probe of our treatment cards, which you can see the runner down in the corner, which is also considered an objective measure. Baseline testing day 2, we also administered the WOB and the 72-item probe. After testing, we went on to treatment, which occurred over 10 days, Monday through Friday, weekends off. The patients came back for treatment Monday through Friday again. The treatment session consists of 20 minutes of real versus fake TMS, and all participants receive 60 to 90 minutes of language therapy, our modified constraint-induced language therapy protocol. The language therapy consists of naming tasks, scaled starting with naming nouns or people in the picture, to the action in the picture, and then combining those items. And we do it in the format of a game like Go Fish. Each patient's therapy is tailored to where they can perform and participate in the therapy. After therapy sessions, the 10 therapy sessions, we did an immediate follow-up and we went through all the 72 items of treatment cards. Participants come back at 3 months, to receive testing. Again, the CCRSA, which was the subjective assessment, the WOB and the 72-item probe, which were the objective assessments, and then occurred again at 6 months. So what did we find? Patient 1, who received real stimulation, had an improvement on the CCRSA, which was the subjective outcome. They also had an improvement on the Western Aphasia Battery, which was one of our objective outcomes. They also had improvement on performance on our 72-item probe treatment cards. But that improvement was not seen in cards that were not treated during therapy. Patient number 2, who also received real stimulation, had an improvement on the CCRSA, the subjective outcome measure. They did not show improvement on the WOB, the objective measure, but they did show improvement on the 72-item probe of treatment cards with a generalization effect, which means their performance was better on not only the cards that were treated during therapy, but on the cards that were not treated during therapy. Patient 3, who received fake TMS, did have improvement on the subjective reported outcome measure, CCRSA, but that didn't maintain through all time points, namely the 6-month time point. Their WOB, their objective assessment, did not have significant change, and there was an improvement on the 72-item probe. Patient 4 had improvement on the subjective outcome measure, the CCRSA, did not have significant change in the WOB, the objective measure, but did show improvement on the 72-item treatment card probe, but that improvement stayed with the treated items. It did not generalize to the untreated items. So what does this mean? Well, our preliminary data suggests that TMS and CILT are beneficial for persons with aphasia. All participants reported improved communication confidence, but that perceived improvement was greater and better maintained across time points for subjects who received real TMS and had greater objective gains on language function, the WOB and the 72-item probe of treatment cards. So in general, the degree of objective improvement in language function after TMS and CILT was reflected in the subject's impression of the benefit as assessed by the CCRSA, the patient-reported outcome measure. Further research is needed to guide clinicians and researchers on evaluating gains in functional language skills in persons with aphasia. I would like to thank you for attending this poster session. Again, my name is Leslie Vanenchek. I'm a speech language pathologist at the University of Pennsylvania. Please reach out with any questions or comments. Have a wonderful day.